Welcome to McPlum, simple solutions served daily.
You must act now. Identify red flags: loss of bowel or bladder, progressive weakness, severe pain. Once those are noted, arrange an urgent MRI and neurosurgical consult within 24 to 72 hours so imaging guides treatment. While awaiting evaluation, use prescribed rigid immobilization for cervical or lumbar spine to limit motion and reduce further compression. Make sure to note medication allergies and current anticoagulants for surgical planning. This first window defines safe, definitive care options. You proceed to the operating room once imaging and consults agree on decompression. The surgical team confirms NPO status and manages anticoagulants. Prophylactic antibiotics are given 30 to 60 minutes pre-op. The chosen operation, laminectomy, discectomy, or corpectomy, removes the compressive element directly, and if the spine is unstable, immediate stabilization with rods, screws, or interbody cage infusion is performed. Stay coordinated with anesthesia and neuromonitoring. Clear communication prevents avoidable neurologic injury. Once surgery is complete, you transition to vigilant post-op care. Monitor neurologic exams, manage pain and nausea, start DVT prophylaxis, and mobilize with physical therapy typically on day 1 or 2. Make sure to wear any prescribed brace and follow a graded rehab program tailored to your surgery and baseline function. If you notice new or worsening weakness, numbness, or loss of bladder or bowel control, act immediately. Obtain urgent imaging and contact the neurosurgeon for reevaluation to rule out recurrent compression or hematoma.
Thanks for watching. Stay juicy and subscribe.